Hello friends, my name is Dr. Ashutosh. I am a physician and welcome to my YouTube channel Medical Lectures by Dr. Ashutosh. In this YouTube channel, I bring to you various medicine related topics which are useful for the MBBS students and also benefit to the BMS, BHMS and other streams of the medical fraternity. So today we will be discussing on a very important topic which is more important for the postgraduate student, and this topic is hepatopulmonary syndrome. Today we will be discussing in detail about the pathophysiology, diagnosis and management of this important disease. Starting with the definition of the hepatopulmonary syndrome. Basically, hepatopulmonary syndrome is a very severe complication of the liver disease, and it is characterized by a triad of three clinical features. First, there will be an underlying liver disease, basically a chronic liver disease, and it usually occurs when there are evidences of the portal hypertension. It means hepatopulmonary syndrome develops in an advanced liver disease. The second important clinical feature is the intrapulmonary vascular dilation, in which there is an abnormal dilation of the blood vessels within the lung. And the third clinical feature is the abnormal arterial oxygenation, which is also known as the hypoxemia. This hypoxemia is actually the result of the intrapulmonary vascular dilation. Now, coming on to the pathophysiology of the hepatopulmonary syndrome. Actually, what happens in this disease, when liver starts to fail, there are various substances and toxins which are not being able to be detoxified in the body. We already know that liver is the main center for the metabolism, but when liver starts to get failed, there are certain vasoactive substances which are not excreted and they start to collect in the blood. These substances cause a lot of pulmonary vasodilation. These vasodilators include nitric oxide, which is the major factor, and there are certain other also like prostaglandins, glucagon and vasoactive intestinal peptides. Due to these vasodilators, there is a massive pulmonary capillary vasodilation, and also side by side there starts an angiogenesis and there is a formation of new blood vessels which also contribute to this disease. Now let's understand how these dilated vessels lead to hypoxemia. Basically, there are the three mechanisms. The primary mechanism is the VQ mismatch. Actually, what happens, we already know that alveoli are the main center from where oxygen diffuses and enters the capillaries. But because in the hepatopulmonary syndrome, there is a vasodilation, so the blood flows very rapidly through these vessels which are widened, and so oxygen does not get time to diffuse efficiently. So indirectly there is an functional shunt. The second mechanism is the diffusion-perfusion impairment. What happens? That oxygen which has already entered the vessels, it has to travel more distance to reach and bind the RBCs. So basically there is a diffusion limitation because the oxygen is not able to bind to the RBCs properly. The third mechanism, which usually occurs in very severe case, is the direct AV shunt, which occurs and it bypasses the alveoli completely. Basically, these occurs between the arteriole and the venules. There is a very interesting phenomena in the hepatopulmonary syndrome. Actually, in other patients of breathlessness, it is seen that when patient is supine, the breathlessness is increased, but when patient becomes upright, the breathlessness improves. But in case of the hepatopulmonary syndrome, it is the opposite. Basically, two phenomena occurs. One is known as the orthodexia and other is known as the platypnea. Now, what is orthodexia? Orthodexia means worsening hypoxemia when moving from lying to an upright position. And platypnea means the sensation of shortness of breath, which is more worse when the patient is upright and improves while lying down. Now, what is the pathophysiology behind it? Actually, when the patient lies supine, there is an even perfusion in the lungs. But when patient becomes upright, the basal perfusion shunt increases due to gravity, and the intrapulmonary vasodilations are more prominent in the bases of the lung. So when patient is upright, due to the effect of gravity, the blood flow increases in these dilated blood vessels, which increases the ventilation mismatch, VQ mismatch, and also increases the shunting, which results in more breathlessness. Now let us discuss the clinical features of the hepatopulmonary syndrome. Basically, the symptoms of the hepatopulmonary syndrome are divided into two types. First, the symptoms of the chronic liver disease, and second, the cardiopulmonary symptoms. So the symptoms of chronic liver disease, we all know, is the severe jaundice and its complications like ascites, spinal angioma, palmar arrhythmia, and GI bleeding. Now coming on to the cardiopulmonary symptoms, as we already discussed, there will be severe dyspnea which will worsen on exertion. There will be platypnea, and also due to the arteriovenal shunt there will be cyanosis, digital clubbing, and because of the vasodilation there will be increased cardiac output which will result into systolic murmur. Now let us discuss how can we make a confirmatory diagnosis of hepatopulmonary syndrome. Actually, no single test is available to make a perfect diagnosis, but we analyze the three clinical features and based on that we make the diagnosis. First, we will establish evidences of the liver disease and portal hypertension by the clinical features which we already discussed. Second, we will quantify the impairment in the gas exchange, that is the hypoxemia. And third, we will demonstrate the presence of intrapulmonary vascular dilation. By these three triads, we will be trying to make the diagnosis of hepatopulmonary syndrome. For quantifying the hypoxemia, we measure the partial pressure of arterial oxygen, that is the PaO2. The diagnostic threshold is less than 80 mmHg on room air at rest. Other criteria is the alveolar arterial oxygen gradient, that is the AADO2, which is a more sensitive marker, elevated if it is greater than 15 to 20 mmHg. Now we define the grading of the HPS based on the PaO2. If PaO2 is greater than 80 mmHg, it is mild. If it is between 60 to 80, the disease is moderate. If PaO2 is between 50 and 60, it is known as severe. And if PaO2 is less than 50, we quantify the disease as very severe. Now coming on to a very interesting test which is known as the bubble echo. Basically, it is an contrast enhanced echo which visualizes the shunt. What we do, we take agitated saline. Agitated saline means saline which has some micro bubbles and it is injected intravenously. Normally what happens, because pulmonary capillaries usually are between 8 to 15 micrometer, so they are so small that normal bubbles cannot pass through it. But as we know, in hepatopulmonary syndrome, the vessels get dilated and its diameter is between 50 to 60 micrometer, and this allows the bubbles to cross into the arterial circulation. Now how do we diagnose? When bubbles are injected, they enter the right atrium and after 3 to 6 heartbeats they will automatically enter the left atrium. So if after 3 to 6 beats of injection, if microbubbles appear in the left atrium, this establishes the diagnosis of the shunt and indirectly it denotes the diagnosis of hepatopulmonary syndrome. There is another test which is known as the MA scan, that is the macro aggregated albumin scan. What happens in this test? Radio labeled albumin particles of the size of 20 to 60 micrometer are injected. Now, normally these particles are trapped in the pulmonary capillaries, but in HPS what happens, because there is intrapulmonary vasodilation, these albumin particles are taken up by the systemic organs. So when we later try to diagnose these particles, we find that about 5 to 6% of these radio labeled particles are uptaken by the brain. So if brain uptake is greater than 6%, it establishes an indirect diagnosis of the hepatopulmonary syndrome. Now coming on to the treatment of the hepatopulmonary syndrome, unfortunately there is no reliable effective medicine therapy available which can revert the disease, but for the supportive care we do supplemental oxygen therapy so as to maintain oxygen percentage to 88 to 90. Now these helps in comparatively relieving the symptom and improve the quality of life, but it does not cure the underlying disease. In past few therapies were tried, but they did not show any promising results. These drugs were noradrenaline, octreotide, pentoxifylline, garlic and aspirin, but these drugs did not show any good result. So now what is the treatment then? Actually, liver transplant is the only definitive cure for hepatopulmonary syndrome. If we do liver transplant timely, so within 6 to 12 months the symptoms of the hypoxemia and the vascular dilation will resolve completely and the patient will get permanently cured. There is also a positive sign that if there is a patient which has PaO2 of less than 60 mmHg, so he will be given priority than other patient for liver transplant. So if we do the liver transplant timely, patient's symptom can be resolved. Now coming on to the prognosis of the disease, you see the hypoxemia gradually increases and it causes ultimate mortality. So if there is no possibility of liver transplant, then ultimately patient will not survive long. However, if the liver transplant is done, the survival rate increases drastically and it leads to the improvement of the symptom and improvement of the hypoxemia. So the whole severity and prognosis depends upon the hypoxemia, and hypoxemia can only be controlled permanently from the liver transplant. So ultimately liver transplant is the only hope, otherwise the patient will not survive long. So friends, this was my lecture on the hepatopulmonary syndrome. Hope you like this lecture. If you find this lecture useful, please subscribe to my channel and also share to the needful. Please give your suggestions in the comment so that we can improve the quality of the videos and make it more beneficial for the upcoming doctor.